All right, everyone, we're going to go ahead and get started. Thank you so much, everyone, for joining. Pleasure to have you. My name's Betty Needle. I am Expert Institute's implementation specialist, and I have joining me Dr. Wendy Ketner, who is our Senior Vice President of Medical Affairs here at Expert Institute, heading up our medical team. And today she's going to be discussing 5 ways expert case validation can expand your practice, which is part of our webinar series in our expert opinions. So we'll have time for a Q&A at the end of the presentation, but in the meantime, I'll go ahead and turn things over to Dr. Ketner.
Thank you so much, Betty, and thank you all for joining us this afternoon. I hope all your families and loved ones are safe. We at Expert Institute have been working from home, but we are a technology company at heart, and we're up and running. We're just trying to do everything we can to help our clients have their practices run smoothly during this uncertain time. So we're very grateful for you being with us. A bit about me: I went to Yale undergrad, then I did my MD at SUNY Downstate in Brooklyn. I stayed in New York City and trained in general surgery at Beth Israel Medical Center before it merged with Mount Sinai. And I've been at Expert Institute about 4 years, conducting medical case validations, done upwards of 1,000 of them. So I'm excited to be speaking with you today. So what is case validation? I think typically when we think about it, we think about just looking at the case for merit, but it's really so much more. I was talking to one of my oldest clients last night, and not by age if you're listening, but by how long we've been working together, about this webinar. And he pointed out to me that a laser approach to these cases is going to be even more important now during this time and post-COVID. I think early medical expertise makes your case stronger, cheaper, faster. And he was saying chances are if it's faster, it probably means you've done a great thing for your client and it settles before going in front of a jury who maybe used to be angry at the healthcare system, but the reality is now we're really viewing all our healthcare workers as the heroes and saints that they've had to rise to be. But taking a step back, I'm going to go through 5 ways that I've seen my clients throughout the last 4 years benefit from reviews over and over again. So avoiding weak cases. I hear commonly from my clients that they tell me they make the most money on the cases they turn down. No one wants to sink a lot of time, money, and effort into a losing case. We can also help build your credibility, giving you confidence that you're making the right decision, both for your potential clients as well as referring attorneys. We all want winners, and we want to get the biggest verdicts and settlements for your clients. So that's what I'll get into on ways 3 and 4. And then the 5th way is really pertaining to when you've already invested in the case and you want to be as prepared and knowledgeable as possible. So avoiding cases that don't have merit. Early on in your case, we want to do a deep dive and make sure you've got a solid case theory with sound liability, causation, and damages. Again, no one wants to lose money. So this case involves a 23-year-old female European professional basketball player, and she had had several ankle sprains, so she was suffering from lateral ankle instability. She went to a small hospital in Connecticut and had it fixed with a device called an internal brace from Arthrex. Subsequently, over the next 6 to 8 months, she had decreased agility. She never really got back to the level she was playing at before, so it caused a significant pause in her career. She decided to seek a second opinion and went to a very prominent sports medicine hospital, and the surgeon said to her, "I wouldn't have done it that way." So was this procedure negligent, or is there more than one way to do this? That was the client's question to me. I looked at both of the operative reports from the first and second surgeons. I researched alternative treatment options, and then I picked up the phone and spoke to 4 practicing foot and ankle surgeons about the case. So my conclusion was that it was not meritorious. The internal brace is an acceptable treatment for lateral ankle instability. Some foot and ankle surgeons prefer just to primarily repair it. They think that the device is a bit difficult to use. But in the end, it really is an acceptable way, and there was nothing in the op note to say they had done anything wrong. I want to point out that this is a very common scenario, as you all know, that a second treating physician, perhaps to be sympathetic to the patient, or maybe the patient misunderstands, that second treater often seems to be criticizing the former treater. But as most of you know, they won't testify to it or even talk to you about it, and most of the time it's a misunderstanding. So I think, before you immediately sign up these cases based on, maybe something your client said to you about something the surgeon or physician said to them, that there are many ways, whether it be orthopedic surgery, general surgery, even choices in heart medication, blood pressure medications, different ways to treat human pathologies that are all acceptable. Depending on where people trained, they may be more comfortable doing things one way instead of another, as was the case here. So another thing I hear from my clients a lot is, they don't want to get sued for legal malpractice, for not working up a case well enough, not doing their due diligence. Others feel an ethical responsibility to at least be able to answer all their clients' questions, even if they're fairly certain that they're going to turn down the case. So that's what this next example is about. So one thing that we do at Expert Institute, especially when we're telling you not to move forward with a case, we want you to feel comfortable with that. We want you to be able to relay everything we've spoken about, all of the due diligence we've done, that you've done, to the client. So we're happy to put together a summary, give an explanation of why the standard of care was followed, provide peer-reviewed literature to really give you and them the confidence that you did your due diligence and they're making the right decision. This is a sad case. A 30-year-old female was involved in a bad MVA in Wisconsin, and she sustained both an ankle fracture as well as an unstable C-spine fracture. She was taken immediately to the OR and had an open reduction internal fixation of the ankle, but her C-spine fracture wasn't able to be stabilized for 2.5 months. This is because anytime you have injury to the spinal cord, it impedes your brain's instruction to your blood vessels of when to dilate and when to constrict. So you can have very labile blood pressure, as was the case with her for 2.5 months, and she wasn't deemed stable enough to go to the OR. And as a result, the patient ended up paralyzed. So this is the million-dollar question, right? Would the patient's outcome have changed if she had been stabilized sooner? This, according to many of the attorneys I speak with, is the most important aspect of a medical negligence case, causation. Early review helps to see if this exists. And I hear also that it's the most attacked part of the case by medical experts on the other side. So I had our part-time neuroradiologist look at the imaging, confirmation that the injury was unstable. It was something called a perched facet, when basically one vertebrae almost jumps over the other, so you're sort of crushing the spinal cord. It's a very bad injury. Did a full record review and spoke with 5 neurosurgeons. So unfortunately, all of the experts agreed that she should have been put in a halo sooner. But with this type of spinal cord injury, the perched facet, as I mentioned, there was just no guarantee that she would have had a better outcome. And so this made this case unwinnable for this attorney. Most of you probably understand this, being attorneys, but I wanted to make the point that we at Expert Institute work with clients in 49 states. We make every effort to examine, your case based on location, what exactly you need to prove. If you have tort reform, if you have a medical review board, things that can make a case harder to win. And again, I think causation is really important to think about. So the firm was able to pass along my written summary with the credentials of the neurosurgeons I spoke with, explaining the Wisconsin law, and the family was very appreciative, although it wasn't the outcome they wanted. So I think this one speaks for itself. We all want to win cases for our injured clients, take on as many meritorious cases as we can. We really do have clients that sign on with us, particularly because they want to expand their med mal, their PI, their mass torts areas of practice, and they simply don't know where to start, or they just don't have the time. we definitely help by saving them time, saving them money, and advising them on which clients to sign up. With our resources, you really can expand your caseload. So I wanted to talk about one that I've been reviewing a lot lately, that's a lot of clients have come to me with, surgical staple misfires. And they have a high fail rate, so it's worth diving into. So how can you tell the stapler is misfired? It's a growing MDL, and it's an important one again. And these staplers, they can jam, they can misfire, the staples can fail to completely close. Due to this, you can have bleeding, leakage of intestinal contents into the abdomen with sepsis, organ and tissue damage, increased risk of cancer recurrence if you don't get all the way across the tissue and don't get a complete resection. Fistulas is when the staple line of part of the bowel is up against another organ, either the bladder or another part of the bowel, and it's leaking against that tissue, and eventually it will erode away the tissue and cause an abnormal connection between either the bowel and bladder, or bowel and bowel, or sometimes even bowel and skin. So again, I mentioned this was an important one. I mean, these numbers are pretty staggering to me. Between 2011 and 2018, there were nearly 110,000 device reports of errors from surgical staplers, including 400 deaths and 3,000 serious injuries. And the FDA is finally now taking, the steps to require more rigorous performance testing on these. So this is simplifying a little bit. I'll get into more detail in the next slide, but things I look at are the time of the presentation, the type of leak, and what was found when they took the patient back to the operating room. So typically we see leaks from a stapler malfunction, misfire, usually occur within a couple days, right? It just doesn't completely close. They immediately start to leak and they're going to become tachycardic fever, and you have to take them back to the OR. If a client presents around day 7, day 9, that's sort of the average of when a connection or anastomosis breaks down if the surgeon has put too much tension on it, or if they put the patient back together in an area of inflammation when they should have diverted the patient, or maybe the tissue is friable. So those would maybe be, could fall into med mal, and less of the staple misfiring. It is worth noting, though, the development of the fistula kind of has that same tissue breakdown, and that can be a delayed presentation. Clients that I probably wouldn't sign up, although there are exceptions to every rule, are clients just predisposed to leaking: smoking, immunocompromised patients, patients on chemotherapy, poor nutrition, diabetes. One other thing worth mentioning, because they are the biggest recall, are the circular staplers used in colon resections. When you fire those in the OR, you should get 2 perfect rings of tissue. We actually call them donuts. And the surgeon should be looking at those in the OR, making sure that they're perfect rings. If they aren't, they should be redoing the anastomosis, and those will be sent to pathology. So you can look at the pathology report and make sure that they were in fact perfect. It's worth noting too that these staplers are used on, kidneys, lungs, heart, other organs. I just focused on the bowel because I'm a general surgeon, but all those cases can be included as well. So damages, right? In addition to causation, you always want to assess your damages, make sure that you're doing right by your client and really figuring out what their future is going to look like. You want to really understand the extent of the patient's injury, because as you all know too well, corporations, including hospitals, are always going to lowball you in settlements. A great example I've heard used involves a 4-year-old girl who had her pinky stuck in, or cut off in a shredder that malfunctioned. The defense figured that she was young, she would adapt, and offered her $500,000, but how many of you would volunteer to have your pinky cut off for $500K? How many of you would do it for $1 million? And they ended up getting much more. So this is what my next example is about. This is another sad case. A pipe blew up on an oil rig where a 25-year-old was working. He flew back, sustained a traumatic brain injury. His phrenic nerve was severed, so he had left diaphragmatic hemiparesis. He also suffered damage to his left neck and shoulder. That was where the majority of the blast went, severing his carotid, injuring his brachial plexus, and he did have PTSD as well. So how do we make sense of these injuries? You know, before you go out and pay a pulmonologist, an orthopedist, a vascular surgeon, et cetera, it's really prudent to tease out what you should be focusing on and which injuries are going to be, you know, the most damaging and the most long lasting. So I reviewed the records for this client, and this is why they came to me. They kind of wanted a little mini life care plan. I found that they actually had repaired the carotid primarily, and too much tension, it leaked, so he required a stent. So he was going to be on anticoagulation the rest of his life. And again, this patient is just 25. He also, after a year of physical therapy, was starting to show signs of complex regional pain syndrome. And this is an important diagnosis not to miss. 10 years ago, we didn't really know so much about this. It was hard to pinpoint, and I think it's hard to blame something on, you know, blame a patient's pain on something that, you know, we don't really understand medically. But we came out with the Budapest criteria, and you need one of in each of one of these in each 4 categories. And they have continuous pain. I won't go into too much detail, but, you know, light touch can cause them a lot of pain. They can have hot and cold flashes, skin color changes, weird sweating patterns, motor dysfunction, and even changes in the hair, nails, or skin. So again, this is part of you know, pain medicine physicians, neurologists. Many people have dedicated their livelihoods to researching this phenomenon. And type 1 is what we formerly called RSD, or reflex sympathetic dystrophy. You have no evidence of peripheral nerve injury. Often it's just a sprain or a minor injury, and that's about 90% of cases. Type 2 is formerly known as causalgia. You do have a peripheral nerve present, so the pain can, you know, even though the blast went to his left shoulder, he's got pain all the way down to his fingertips, his neck, his chest, and that's about 10% of cases. So the bottom line is we don't have a cure. We have some medications we can give, including, you know, things we give for nerve pain like gabapentin, NSAIDs, opioids. But now you have, you know, a 25-year-old client who already has a traumatic brain injury, may have personality changes and need medication for the rest of his life for that, is suffering from PTSD. And now you're telling him he's going to be in severe pain the rest of his life, and there's nothing, you know, you can do for him. And I've seen a lot of clients have success making this diagnosis in their personal injury cases. I think particularly as people are sympathetic to the opioid crisis, and you know, they really want to be empathetic to these patients and the compensation that they deserve. So we got the firm a great neuropsychologist to see the patient, document that he was still having night terrors and flashbacks from nearly bleeding out on this oil rig, an oil rig safety expert, a mechanic working on a similar rig to dig into whether, you know, proper maintenance checks were done and how this happened, and then of course one of the top leading experts in CRPS in the nation. So last but not least, and thank you to everyone who is still with me, optimizing your cases for success. Maybe, you know, your expert is in the OR, you don't want to pay them for a half an hour quick rerun through the anatomy and questions you should be asking. Me and my team, we want to save you from going down the black hole of Google and YouTube and really get you ready to fight your case. This was a 40-year-old mother of 3 young kids. She had a minimally invasive mitral valve repair, so they do a cut down over the femoral artery in the groin and get to the heart that way. Post-op day 1, she was transferred from the CSICU to the telemetry floor, and she ended up bleeding out from the access site and died. The attorney originally got a negative review from a cardiac surgeon, but they were in a good jurisdiction and they couldn't accept that this woman needed to die and really wanted to do something for these 3 young kids that had just been orphaned. So the attorney came to me the night before the deposition of the telemetry nurse. And what I discovered was that there were missing records. The medication administration records were missing. And I guessed that probably the patient was still on pressors when they released, pressors being medications that control your blood pressure when it gets too low. And increased need of pressors is definitely a sign of bleeding. So they discovered in the deposition that I was right. The telemetry nurse agreed and said the patient probably was still on pressors. They called me in the middle of the deposition and we just went through the differences between the CSICU and the telemetry floors. And it's this is one of those tragic cases that you just don't think happens in the 21st century, like giving someone the wrong blood type and causing a fatal transfusion reaction, or operating on the wrong limb. God forbid it was an amputation, but it does, and we've seen it all at Expert Institute. But you can see some of the differences here. The main one being in the CSICU, you have a much better nurse to patient ratio. You have continuous vital signs, including continuous blood pressure, as well as oxygen saturation, and those pressors are titrated. I mean, I'm only guessing here, but I think the original surgeon's negative review might have been because the patient was young. She's not going to show that she's bleeding quite as fast as a 70-year-old or an 80-year-old with less cardiac reserve is. She had a really rapid decline. And when you bleed from these access sites, you don't bleed forward towards the abdomen to show that you might have a bump there bleeding. You bleed into your back, so they're harder to detect. And every CSICU is as close as possible to the OR for just this reason. Cardiac and vascular surgery patients often need to get back to the OR within minutes. Mine was about 20 yards door to door, and I felt that if she had been there, they could have saved her, and the jury agreed. So I hope this has gotten your wheels turning on how you can lean on me and my team to help with case reviews, validation, preparation. I just want to touch on who we are and a few more ways we can help. Our full-time job really is to help you be the strongest advocates you can for your client. Collectively, we've reviewed more than 15,000 cases, but we're not limited to record review. Case clinics are our bread and butter, but we can help with imaging reads, get you on the phone with key opinion leaders. We're available for quick questions, deposition prep, literature reviews, really anything, everything we can do to help you. We take our jobs with a tremendous amount of responsibility. It's not lost on us that you all are the ones sitting across your desks every day from injured parties whose lives have been turned upside down by medical or corporate negligence. And we think about that all the time, and we want to help. We want to help you get them, what they deserve and get them back on their feet. So with that, thank you so much for joining, and I'll take any questions you might have.
Thanks so much for that, Dr. Ketner. That was incredibly informative. So we will open up the floor to questions. Feel free to type them out, and we will have Dr. Ketner go ahead and address those as they come through. I can go ahead and kick this off here. Could you give us an idea of what might have been the most complex case that you've ever reviewed during your time at Expert Institute?
Most complex. Well, I think breast cases are always difficult. It's wonderful for the breast cancer patients that we've done so much research. We know so much about the biology of the tumor. We have a lot of good treatments now, but they often are difficult because we know so much. I had one that was a phylloides tumor, which actually is not a breast cancer, it's a sarcoma. And they're very, very rare. So we don't have a lot of good randomized or even retrospective trials on how to treat these patients. So anytime something's really rare and we don't have a great standard of care, that's difficult. This case was also complicated by the fact that her pathology was read 2 different ways. So that was a difficult one. Another thing that comes to mind, and this is not a specific case, but not an uncommon scenario, where a client comes to me and says their client is, a sweet old lady. She just lost her husband. They were in the CSICU or the SICU for 6 months. They had 3 surgeries. They were seen by infectious disease, cardiac surgery, cardiology, critical care, nephrology, the kidney doctors, and the client doesn't even know what happened or how her husband died. They didn't do an autopsy. The doctors weren't very good at communicating. And so we kind of have to delve into those and take a group approach. Usually with those, we'll have one of the surgeons as well as our critical care physician on staff take a look to try to figure out who's liable, just because there's so many moving parts.
Thank you. And we have some more questions coming in. Here's one I think would certainly fall within your wheelhouse. Should spleen injury during colonoscopy be avoided? And what would we look for to see if an unavoidable consequence or negligence has occurred?
So I've reviewed a bunch of these. The truth is the devil's in the details, but it should be avoided. There are techniques that you can use while going around the splenic flexure to avoid putting too much tension on the splenocholic ligament and having that tear. And I have found supportive experts for that.
Great. And another question, what determines when more than one medical expertise might be needed?
I think the most common time is when you need someone different for causation and liability. So for instance, let's say a GI surgeon perforates the colon while they're, the spleen, and then you want someone else, actually this is rather a damages one, you want someone else to talk about the damages of having to have a splenectomy. I think obviously we all want to try to keep costs down for our clients, but there definitely are times where you just need someone else for liability, causation, and damages.
Agreed. And
going another one that might be, an ER doctor misses a stroke. So you'd want an ER doctor for liability, but you really want a neurologist to talk about, the damages.
Another question, someone asked that the stories or examples that you gave were examples of large damages that were brought to you, or maybe slam dunks of cases. What about cases where they are more gray area, or as was mentioned, run of the mill? How might you and your team take a look at those types of cases?
Yeah, that's a great question. Again, we work with clients across 49 states. We certainly, don't want to tell you you have a case when you do have a case. That said, we think like plaintiff's attorneys. We want to find you an angle if we can. People have different risk tolerances. States have different rules, but we certainly do not always, just say to move forward with slam dunk cases. There are gray areas, and if I tell you after reviewing it that I think you should move forward, then it's my responsibility to go out there and find you an expert that can get on the stand and say they've been doing that procedure or treating these patients for 20 years, and that damages has never happened to them. Or hopefully that answers your question.
Absolutely, and I think this next question will segue nicely into that. We had a question about the time commitment for getting that opinion or validation before turning down a case. So would you mind walking us through that process a little bit more, and what might that look like for both the attorney and then for your team as well?
Sure. So I think the first thing to remember on that is it's never too early to get us involved. Even if you have a couple pages of records, you just have a fact pattern, you have, all firms have an intake sheet from a client, you just want to give us a quick ring and discuss it and sort of talk about different ideas, that's fine. Once you do have the full record, usually you can send it over to us. We can get it scheduled within about 7 to 10 business days. And we will have spoken to, practicing physicians as well as doing our own research, and can have that half-an-hour conversation. And then if we do decide to move forward, I guess I'll take it a step further. We will do outreach to experts, and we typically find experts in 3 to 5 business days. Of course, if you have any deadlines, we're always making sure that the experts we find you can meet those, whether it be a report, an affidavit of merit, an SOL coming up, and everything we do at Expert Institute can be turned around faster than those deadlines that I just said. I mean, I've had a client come to me on a Friday, they needed someone to go up to University of Rochester to read pathology slides by Monday, and we got it done. So anything we do, we can be expedited for you. We know things happen, we've heard it all. You know, my expert passed away, my expert sent, you know, their report to the wrong attorney. So we're here to help.
And again, segues into my next question nicely. This is from a working nurse who said that they've reviewed cases for the last few years, and an attorney called the nurse, and the nurse explained the details of the records and could not support the plaintiff's position, and the plaintiff, you know, reacted badly to that. So what resources or sort of support do you have put in place to help maybe mitigate that?
So I think I understand the question. I think it's that the attorney comes back to you saying the plaintiff isn't happy, can you do it again? Yeah, this is always a really difficult situation. Injured parties are, you know, extremely emotional, as they should be. I think the best you can do, and the way that we do it, is, you know, writing out those summaries that really detail why the standard of care was followed, or why there's no causation, with supporting literature, everyone that we've spoken with. You know, and I think the only thing you can do for the potential client or the plaintiff is, you know, get the review done in a timely fashion so that they have time before their SOL runs up to take it to another attorney.
Great, and just wrapping up here with the last few questions, we did have a question about what might these services or case validations cost as a ballpark. So would you mind shedding some light on that?
Yeah, so our costs are all based on usage. There are two ways to work with us. One is you come to us, you just need an expert. We're very candid about that. It's on our website. We charge a $2,500 finder's fee for that. Of note, we have no financial relationship with our experts. That's the only fee we take in. We don't mark up their prices. They don't pay us anything. We don't pay them anything. And we, of course, intentionally designed our business that way for optics-wise. The second way is on a partnership, and that's what gives you access to my team and more of the services that I was talking about today. And that's usually based on firm size as well as just your usage. We start that out on a 6-month trial. And again, we work with solo practitioners all the way up to, you know, gigantic firms, and they don't pay us the same amount. So it is just based on usage, but feel free to email me and we can go into a little bit more depth about your particular firm.
Well, thank you so much, Dr. Ketner, for answering all those questions and giving your, you know, personal experiences with this case validation process. And to all of our attendees, thank you so much for joining. And as I did mention, this is part of a webinar series, so just be on the lookout for that. But in the meantime, hope everybody is staying safe and healthy out there, and please feel free to reach out if there's any way we can help.
Thank you, everyone. Stay safe.